Thanks for joining. Today I'm going to be talking about work that our lab is doing to help bring clean water to cities in low-income countries. And I just wanted to note that I'm faculty in the School of Engineering at Tufts in Civil and Environmental Engineering, and I'm also core faculty at the Center for Integrated Management of Antimicrobial Resistance at Tufts. 2.2 billion people lack access to safe water globally. In 41 countries, as you can see on this map shown in orange, more than 1/5 of the population uses an unprotected drinking water source, such as a surface water source or a shallow well. And I just want to break down water access into three components. Most people throw around this statistic, 2.2 billion people, but I wanted to try to unpack this a little bit to understand what lacking safe water really means. So you can think about accessibility. So having access means that water is available in your home. And then there's availability. So water is available when it's needed. And then finally, quality. So a safe water source is free from microbial and chemical contamination. So let's talk a little bit about accessibility. So 2 billion people don't actually have water on plot in the world. And this translates into a high burden for many poor households. It's estimated that 16 million person hours per day are spent fetching water in sub-Saharan Africa. And just to put that into perspective, 50 liters of water weighs over 100 pounds. And it's true that women and girls actually bear the burden of the water fetching burden in sub-Saharan Africa. So this is a figure showing in purple the percentage of households in a women or girls are bearing the primary responsibility for fetching water. And so it's not surprising that this water fetching burden actually has negative effects on child health. When people have to walk far distances to fetch water, they tend to collect less water, so there's less available for hygiene, hand washing, and bathing. Having to store water in the home increases contamination. There's less time for mothers to spend on caring for their children. And in fact, we've done some analysis where we found that a 15-minute reduction in one-way walk time is associated with important child health outcomes, such as a 41% reduction in child diarrhea and 11% reduction in child mortality in sub-Saharan Africa. So in terms of availability, there's actually a lot of cities around the world where water is available through what would typically be considered an improved water source, like a pipe water supply, but it's only available for a limited duration. And actually 50% of the population served by pipe systems in Asia receive water intermittently, 30% of the population receives water intermittently in Africa, and 60%, almost 2/3, in Latin America. So this is a map showing the mean numbers of hours of water supply per day in these countries. And so you can see in the darker blue areas, in some countries, on average, water is available less than 10 hours per day at the tap. So in terms of water quality, improved water supplies, partly because of all of these intermittent systems, are not always providing safe water. So for example, in Nepal, even though 91% of the population accesses an improved water source, such as from a bore well or a pipe supply, only 70% of the population actually drinks water that's free from E. coli contamination, which is an indicator of fecal contamination from sewage. So part of the motivation for the work that our lab does is that I would say historically there's been really two dominant paradigms for providing water in the world. And so we have centralized treatment, which we have in the US and in Europe. And so this is very capital intensive infrastructure that's prohibitively expensive for low resource settings. And it's also not compatible with intermittent supply, because when you're treating centrally, by the time water reaches the tap, it's going to be contaminated, because water, when there's intermittent supply systems, there's unpressurized events in pipes, and that is when contamination can get sucked into the pipe. And then there's been this movement of household water treatment where the idea has been to try to develop household level products and technologies and strategies to empower households to take charge of their own water treatment situation. However, it's been very, very difficult to achieve sustained usage of these types of products among poor households. And there's been really low demand and low adoption rates of these products around the world. And I just want to give one example of a program in Kenya that kind of demonstrates this issue, I think, quite well. So in April in 2011, the private company Vestergaard Franson freely distributed almost 1 million LifeStraw family filters to over 4.5 million people in Kenya's western province. So the idea was every single household was supposed to receive a filter. And they were planning to pay for this program by getting carbon credits for basically claiming that they're moving people away from boiling their water to using this filter to treat their water. So at the time, I happened to be involved in a large trial where we were enrolling 8,000 households in the same area. So you can see these red dots are all of our study households that happen to cover a large area of the program area. So we decided to insert into the survey that we were conducting questions about usage of the filter to kind of compare how our usage rates might compare to what the company was claiming. And so here we're looking at a figure where we see monitored usage by the company over a 3-year period. You can see it's quite high, over 90% after 6 months, remaining quite high throughout the period, and they were able to receive a large number of carbon credits for this program. However, let's look at our household data, which looks a little bit different. So we found much, much lower rates of usage of the filter. And when we actually asked households what the issues were, many said that the filter was too slow, it broke easily, it was too complicated to use, it was difficult to clean, it didn't actually provide a way for them to store their treated water safely. So there were a lot of issues with this product not actually meeting the needs of the users that were expected to use it. Okay, so when we think about all of the different types of water treatment strategies for low resource households, we can kind of make this figure with cost on the y-axis and behavior change on the x-axis. And so you can see something like central disinfection requires very little behavior change, but is very, very expensive, versus something like solar disinfection, where you're putting water into plastic bottles and placing them on the roof for 8 hours, requires a lot of effort and a lot of time, and may not actually result in water that's that palatable to drink if it's warm or tastes like plastic. So you can see there's a spectrum of different options here. And what our lab kind of realized was that there weren't a lot of people working in this white space for innovation, trying to develop technologies and strategies for water treatment that would provide a similar level of service to what we have in the US and Europe and other high-income countries, but still didn't place a large burden on the user. So when we started thinking about how we could do this in Bangladesh, we made a list of kind of the ideal criteria we'd want for a water treatment strategy. And one important thing was that we didn't want people to have to change the way they were normally collecting their water. Of course, we were worried about cost, keeping it low cost for sustainability and scale-up reasons. We didn't want the technology to rely on electricity because electricity access is unreliable in places like Dhaka, Bangladesh, and other low-income cities. We wanted it to be compatible with intermittent water supplies, since they are becoming the norm in Asia and Africa. And we wanted also to be able to provide some residual disinfection. Many, many people store their water, and that's a behavior that's not going to go away. And so when we made this list, we realized that chlorination is actually a strategy that meets many of these criteria, or could meet many of these criteria. It's very, very low cost. It's extremely effective at removing bacteria and viruses from drinking water. And if you can automate it, then it should be able to basically make water safe by default as it's coming out of the tap or a hand pump. Okay, so once we had done that kind of needs assessment, we developed a research agenda for this project, and we knew that we couldn't just develop a solution in the lab in the US and expect it to work and be scaled up around the world. So we started working on a number of different components, and really this is a very interdisciplinary project. It's requiring social science and engineering and economics to understand everything we needed to think about to actually make a solution that was going to be sustainable. So we worked on acceptability. So for example, what level of chlorine dosing could optimize uptake and efficacy. We started thinking about what are the technologies out there for automated chlorination? Are they appropriate and affordable for low resource settings? We wanted to evaluate the impact of the approach. So, if we are able to roll this out, would it actually improve child health, given that there's so many exposure pathways in urban areas for diarrheal disease? And then finally, we wanted to think about how could this be financially sustainable, and what would be appropriate ways to scale this up. So I'm going to talk a little bit about this work that we did, and all this work that I'll be talking about today has been done in Dhaka in Bangladesh and in Kisumu in Kenya. So let's look at Dhaka first. In Dhaka, 220,000 people live there per square kilometer. It's a very, very densely populated place. There is a municipal network where you have 10 to 50 households sharing one water point. Unfortunately, they are over extracting their groundwater in Dhaka, and the water table is falling 2 to 3 meters every year. So there's definitely an intermittent supply problem, and that problem is getting worse. So there's also very poor sanitation in Dhaka. This is a picture showing hanging latrines. So when you have toilets just placed over surface water bodies in Dhaka, that's actually been estimated that in Dhaka, 98% of human waste just flows directly into the environment. And so you have drinking water pipes flowing through open sewage and drains, and highly contaminated environment. And so contamination in the pipe supply is quite common. And so when we surveyed 127 community water points in 45 different slums in Dhaka, we found that indeed the water was quite contaminated. Over 80% had E. coli in it. The centralized treatment system that was available in Dhaka was obviously failing and not appropriate for the intermittent supply system. And there had been a number of studies trying to promote household water treatment products, and found that people were not using them. For example, one study found that less than 30% of people were using water treatment products, even when they were handed out for free. So the first thing we wanted to do in Dhaka was figure out what dose would make sense to optimize disinfection, but also acceptability of potential end users. And we knew that chlorine could be a taste barrier to adoption based on the piloting that we'd done in the area and our preliminary work. So we did actually a taste test experiment. Turned out that no one had really done this before in Bangladesh. And what we did is we gave users, residents in Dhaka, a series of 3 cups where one of them had a chlorine residual in it, and the other 2 didn't. And we did that in triplicate to see at what level of chlorine residual could they actually reliably pick out the cup that had the chlorine in it. And then we also asked them, just their perception. Could you rate the taste of the water as, good or poor or worse? And so from this experiment, we were able to figure out the median detection limit for users in Bangladesh, and we found that to be 0.7 ppm, free chlorine residual. And we also found that the acceptability level was a little bit higher at 1.2 ppm. And this was really interesting because it turns out that most household water treatment products actually dose between 2 to 5 ppm, which is far above what these users are actually saying is acceptable to them. And so this was something that was very valuable to us for the technology development and also for the impact studies that we wanted to run to see if we could dose at a much lower level than is typically done to increase acceptability of chlorine in the water. So the next thing I wanted to do is figure out what types of technologies would work well for the infrastructure in Bangladesh. And when we first started this project, I thought that we could just find some off-the-shelf technologies and use them to dose chlorine automatically into the water without relying on electricity. But it turned out there were really no technologies available off the shelf. So we ended up having to develop one ourselves. And what we wanted to do was design a low-cost liquid chlorine doser that didn't rely on electricity and that used liquid chlorine is the chlorine source because dilute bleach or bleach is widely available in low resource settings all over the world. And so that's very attractive to have the refills for the chlorinator be so widely available. And there's also been some new products coming onto the market in the past couple of years called electrochlorinators, where you can just take salt and water and make a chlorine solution with just a little bit of electricity. And so being able to use that type of chlorine source was very attractive to us and could drastically reduce the cost of operation. So we ended up taking multiple 3D printers to Dhaka, and we had a team of Bangladeshis from the International Center for Diarrheal Diseases Research and a Bangladeshi engineer who was fantastic, and we had a team of students working on this for actually 2 years, I think it took, to develop what we ended up designing was a doser that used the principles of fluid dynamics to dose just the right amount of chlorine into the water. And we were able to do this by engaging with users on the ground and using a human-centered design process where we had the users involved in the tech development throughout the process. And it was a very iterative process too. And having the 3D printers in Dhaka was super useful because we could rapidly prototype based on information we were getting from the testing. So this is a diagram of what we ended up designing. We call it the Venturi doser. It doesn't require electricity. It's compatible with varying flow rates and intermittent supply. And you can adjust the dose of it as well to accommodate different levels of chlorine demand. And it takes liquid chlorine solution, so you can buy it usually off the shelf in a lot of places in Bangladesh and in Kenya, or you can dilute bleach to make the chlorine solution to refill it. And we've actually partnered with a commercial partner who's interested in the product, and this is our new design for mass production. And so we're estimating it's only going to cost $35 per device to manufacture this. Okay, so that's the technology that we came up with. Now I want to talk about an impact study that we did also in Bangladesh to try to understand how automated chlorination at the point of collection could protect children from diarrhea. And there were a couple motivations for this trial. One is there had never been a trial done with this approach, so automatically chlorinating at the point of collection at the tap. Most previous trials had been for water treatment products. We also wanted to do a blinded trial because our main outcome was diarrhea, and there can be bias with that outcome if you tell people which group they're in. And so we ended up using not the technology that we had been working on because it wasn't quite ready when we started this trial, but a solid tablet chlorine doser that had come onto the market while we were developing our technology. And this was a technology that could be installed at the inlet of tanks and water would flow through. It didn't require electricity, which was great, and the water would flow through and disinfect the water as it flowed into the tank. So it was compatible only with water points that had tanks, but a lot of people had tanks in Bangladesh because of the intermittent water supply problem. And so we adapted this technology to the infrastructure in Dhaka to do this trial. So we had a study design where we had a randomized controlled trial. So we had 50 water points randomly assigned to treatment and 50 water points randomly assigned to our control. And we had identical dosers in each group, where half dose chlorine and half dose vitamin C in the control group. And we had the dosers installed for over 1 year. So here we can look at the chlorine dosing performance in the treatment group. So we specifically started the dosing low in the beginning of the trial to get people used to the taste. But we also tried to dose below the taste detection limit throughout the entire trial in the treatment group to ensure that we, kept our solution acceptable to end users. And so the dosers performed really, really well. We had over 80% of taps had a chlorine residual when we sampled them in the treatment group over the course of the trial. And we found big reductions in E. coli contamination in the treatment group. So in terms of the effect on child health, we saw a pretty substantial reduction in diarrhea in the treatment group. So the 23% reduction in diarrhea among children in the treatment group compared to the control group. And where we had study sites that were in areas that had even greater intermittency in the water supply, we found even larger reductions in child diarrhea. It was very encouraging. And it was great to see these child health benefits when we were dosing at that low level, because we were worried it might not be as effective to dose at such a low level, but it turned out it was. And so in terms of if the blinding was effective in the trial, not surprisingly, it really was. So most people thought they were in the control group. And even when we asked them to guess what group they were in, most people thought that they were in the control group. And so you can see here the percent of people guessed based on what group they were in. So we also saw some other benefits from the intervention that were quite encouraging. In the treatment group, there was an 11% reduction in healthcare costs spent on illness related to waterborne disease. There was reduced antibiotic drug consumption in the treatment group, and households in the treatment group were also 30% less likely to seek treatment for gastroenteritis. So this was the first trial of this approach to automatically chlorinating at community water points in Bangladesh. And so it was also the first blinded trial of a water treatment device in the low-income setting to actually be able to detect an effect on diarrhea, which was encouraging. And finally, because we were dosing at this low level, it was very encouraging to see that we saw these reductions in child diarrhea, even though we were dosing low to increase acceptability. Okay, so now that we know that there are health benefits from this approach, we also kind of simultaneously to doing this health impact trial, we were also thinking about what business models could work to scale up this approach. And so I'm going to talk about a business model that we tested out in Kenya, in Kisumu. And so this was actually with the technology that we had developed in Bangladesh, the Venturi. And so what we wanted to do is try to see if we could harness kind of two levels of entrepreneurship in Kenya. So we have our commercial partner, MSR Global Health, who manufactures the technology now. And we partnered with a distributor in Kenya, an NGO called SWAP. And they agreed to sell different types of service bundles to kiosk owners, water kiosk owners, who were already selling drinking water to customers in Kenya. And so the idea here was that the distributor could make money by selling or leasing the device to these kiosk owners. And then the kiosk owners could actually potentially recover their costs by charging maybe a slightly higher price for water, or selling more water in general at their kiosk, because they could offer a treated water source. So we ended up actually going forward with this pilot, and we were able to sell the Venturi, different sales packages I'll talk about in a minute, to these kiosks. And it was also a great way to test our new technology and make sure it was performing really well in a field situation. And another thing that was kind of cool with the pilot was that we got to see if customers chose to purchase treated water versus non-treated water at the kiosk, because they had the option, because the kiosk had multiple taps, and we put the Venturi just on one of the taps. So this is just a diagram of the study. We recruited kiosks, SWAP made a sales pitch to them. Then if they agreed to purchase a service package, we installed the device, and we conducted weekly monitoring of the technology to make sure it was working well. We also collected monthly payments from the kiosk owners, or SWAP collected the monthly payments. And then we did some surveys to kind of see how the kiosk owners felt about the device and how customers perceived the device as well. So these were the different types of service packages we offered to the kiosk owners. They could either lease the device, or they could lease the device and also get chlorine refills delivered to make it super easy for them if they wanted to pay for that service, or they could lease to own the device, or they could lease to own the device and do chlorine delivery. And so we did this because we wanted to see, what would be the best service package to offer in this area if SWAP was going to run this business. And so we had 1/3 of the kiosk owners that we offered a sale actually purchased one of these service packages. And it was interesting because we had a couple choose each type of service package. So it kind of indicated to us that these were all good options to have to meet a larger target market. And in terms of the payments, so over a 6-month period, this is showing you the total amount of money that these kiosks paid to SWAP for this technology. So you can see actually quite high prices. So some of them paid over $270 to lease the device and receive chlorine deliveries for the 6 months. And so we had 6 out of the 7 kiosks that purchased a service package actually paid in full. And 2 of the kiosks that leased actually decided to purchase the device after using it for 6 months, which was super encouraging. And it was really interesting because each kiosk had its own sales strategy. So this is a picture showing a kiosk owner who converted our device into a mobile device and kind of traveled around to different villages based on where he thought there might be more customers. He actually made the most money out of all the kiosks. So we had these devices installed for a 6-month period, and they performed really well. The technical performance was excellent. We had 95% of water samples that we tested had chlorine in them, and it was able to dose pretty accurately at a low chlorine residual, which was good too for acceptability. We actually recently followed up on these devices, and they've been owned by these kiosks for 2 years, and they're all still functional and being used. So I also wanted to briefly mention a business model that we also tested in Dhaka in Bangladesh. So here we have quite a different kind of infrastructure for providing water in Dhaka. So people don't actually pay for drinking water in Dhaka. They tend to rent from a landlord and then pay rent to that landlord on a monthly basis, and their water point is in their compound, and they get access to that water point through paying rent. And so here we needed a very different business model to think about how we could scale up the device. And so here our hypothesis was that the doser could offer a competitive advantage in rental housing markets. And then so the landlord could lease the device and receive the chlorine refills in Dhaka. It's a bit harder to purchase chlorine solution in Dhaka than it is in Kenya. So we felt like we should offer that chlorine refill service to landlords. And then they would pay a monthly fee, and they could charge just a tiny amount more to their tenants to cover the cost of that leasing fee. And so we did an actual auction in Dhaka where we asked landlords to bid one of 6 prices for the monthly service, and they won the auction if their bid was greater than the randomly assigned price. And so we had landlords bidding a mean bid of $50 per year for this service. And we sold 88 of the devices to landlords, and most of them successfully paid for the full year of service, which was very encouraging. So I think I just wanted to summarize by saying that hopefully I've shown you all that this approach, automated chlorination at the point of collection, can overcome a lot of barriers to safe water access in low resource settings. We really focused on trying to develop an approach that didn't require users to change the way that they normally collect water. We were able to develop a technology that doses at a level that's acceptable to users, which I think could solve a lot of the issues of scaling up chlorination in low resource settings. And the technology that we developed really reduces operational costs and increases the target market over what's available currently through other technologies, such as solid tablet dosers that require tanks and require you to import tablets from other countries. And we also demonstrated there's effective demand for this service in a lot of low resource communities. So right now what we're doing is we're recognizing that there's going to be different business models needed for financial sustainability in diverse settings. And we also think that there might not always be a way to sustain this in the private sector. We also think there's a role for strategic partnerships with NGOs and governments strategy. And we're also in the process of getting the tooling and molds, raising funding for those to do mass production of the Venturi device to bring down the cost of it, to make it more accessible to partners around the world. I'll close by saying that the new Sustainable Development Goal is to, by 2030, achieve universal and equitable access to safe and affordable drinking water for everyone. And so this, if some of you are not familiar with the MDGs, this is actually a goal that's much more focused on water quality than the previous drinking water targets for the MDGs. And I think that automated chlorination, this work is very relevant because I think it's going to be a key strategy for trying to meet this ambitious goal by 2030. So I wanted to acknowledge all of the amazing partners who have contributed to this work, our partners in Bangladesh and in Kenya, and our funding sources that have made this research possible.